All right, good morning, everyone. Good morning, everyone. We're going to go ahead and get started with grand rounds this morning. Thanks for your patience today as we get started. Today we're going to have Dr. Flanagan speak to us, and to present her, we're going to have Dr. Javid come up here.
Sorry to keep you all waiting this morning. I'm honored to introduce Dr. Meghan Flanagan today, who most, if not all of you, know well as a superb clinical breast surgeon and teacher on our breast surgery section, as well as an educator here. I've known Meghan since she was a junior resident here at UW, when she was in many of your shoes on T32 fellowship grant, doing research and coming up with novel ideas and bringing them to their fruition, no matter how many databases she had to figure out and how many statistical modeling methodology she needed to learn. Now, she is our core leader of Division of Research at UW Department of Surgery. We were elated as a section to successfully recruit Dr. Flanagan back to UW in 2018 after she finished her breast fellowship at Memorial Sloan Kettering. Since that time, Meghan has been nothing short of a superstar. I appreciate her every day as a clinical partner, whom I credit with the development and growth of a very successful breast surgery program at Northwest, a sounding board for tough clinical cases, and an encyclopedia of knowledge on all the recent literature. I am regularly in awe of her research productivity, both in terms of publications, 31 and counting, and grant funding, 5 just right now, as well as her translational research on the HSD3 beta genotype in postmenopausal breast cancer, which she has presented to us in previous grand rounds. Meghan is brilliant, hardworking, and humble, and is the first to envelop others around her in her success. She has done so as a mentor to several in this room, including Dr. Nina Clark, Dr. Jamie Olapo, Dr. Malia Brennan, and medical students, whom we ultimately attracted to our general surgery program, like Dr. Sarah Brennan, getting them to regional and national presentations on stages as varied as ACS and American Society of Breast Surgeons. Locally, Dr. Flanagan serves as a COC Cancer Liaison Physician, Director of the Northwest Breast Clinic, and member of the UW Women's Council. She will also serve as a new fellowship director to a newly minted breast surgery fellowship program beginning in 2026, which she played a pivotal role in building, and was recently awarded the Next Invited West Coast Collaborative Visiting Professor at Stanford. Nationally, Dr. Flanagan serves on the NCCN's Breast Cancer Screening Panel, the SSO Research Committee, and the Translational Breast Cancer Research Consortium, where she collaborates with others and leaders in breast cancer on developing research plans on controversial issues in our field, including those you'll hear about today, entitled in her talk, In Pursuit of Precision, Breast Surgery Research at the University of Washington. With pride, I reintroduce you to Dr. Meghan Flanagan.
Thanks so much, Sarah. Like you have over introduced me. Okay, so hopefully everyone can hear on Zoom and hear. Can you guys all hear me in the back? Okay, great. So the title of my talk, In Pursuit of Precision, I think probably applies to what all of us do in surgery here, and is actually, unfortunately, not going to represent all of the breast surgery research that we do here, but just a small proportion of it that I particularly work on with my colleagues in both the breast surgery section and also throughout our multidisciplinary group who care for breast cancer patients. These are my disclosures. You will see some slides hopefully later in this presentation from Perimeter Med and Intuitive Surgical, our ongoing research industry-sponsored trials that we're working on. The remainder of the disclosures are not really relevant to the topics in this conversation or in this talk. So some of you may have heard of this concept of precision oncology and what kind of precision means in terms of how we take care of our cancer patients. Really, this phrase came from people who are essentially developing specific drugs. So patients and their specific tumors, can we find specific mutations or druggable targets so that we can improve outcomes and decrease toxicity for our cancer patients? Many of you may have also seen emails or seen press releases that the Sloan family gave a very large gift to the Fred Hutch within the last couple of years to build a precision oncology research institute. And I think I looked on their website and I really like their take on it, which is we take a broad view of precision oncology. So not just drugs, but looking at risk prevention, diagnosis, and treatment. And I think as surgical oncologists, we never want to be left behind. And because many of us are not actually developing drugs with pharmaceutical companies, I really like how they kind of incorporate all the aspects of cancer care. And I think that a lot of my research that I've been particularly interested in really stems from the patients and wanting to take each patient and their cancer and their sort of values and goals as a whole and incorporate them into their optimal cancer care. So the details of this slide are not particularly important, although it did take me about 2 hours to put this together. So really focus in on it. If you go to any breast surgical oncology meeting recently, there's a lot of, or actually breast oncology meeting, there's a lot of talk about quote unquote de-escalation. And as I was putting together this slide, I actually noticed that most of the de-escalation had to do with local regional treatment. So mastectomy to breast conservation, axillary dissection to sentinel node biopsies. Let's omit radiation in women who have low risk tumors over the age of 70. Let's maybe not do sentinel node biopsies at all for some people. We can do multiple lumpectomies now instead of mastectomies, and we can maybe do 1 week of radiation instead of 3. On the other side, when you look at the escalation side, aside from the Halsted mastectomy in the 1800s and cobalt radiation in the 1950s, most of it actually has to do with drug development. So Herceptin and tamoxifen, specific targeted drugs for different types of breast cancers, Kadcyla and olaparib, which are specific medications. Pembrolizumab is a checkpoint inhibitor. Abemaciclib, most recently approved in 2023 as a CDK4/6 inhibitor. This sort of escalation or specificity of systemic treatment options has actually led to the ability to de-escalate some of our local regional treatments. And it kind of highlights how we're all sort of coming together to try to find that just right fit for our oncology patients. And this is obviously the goal here in the upside down triangles, decreasing mortality. So we want to improve the survival of our patients. Despite the fact that breast cancer incidence has actually been increasing more recently, and I saw a statistic last week that instead of 12% of patients having breast cancer in a lifetime, it's now actually 13.3%, which is somewhat concerning. But we have consistently been able to improve on survival outcomes for our patients. And a lot of that does have to do with the increasing systemic therapy options that we have for them. When I was putting together this talk, trying to think about the scope of breast research in our section, I quickly realized that there was zero possibility I would ever be able to present on all of it. So most of the research that I'm going to talk about today has to do with projects that I specifically am working on with my group, but we also span the gamut of different types of research interests. Even though there's only 5 of us dedicated breast surgeons, we really have been able to accomplish a lot in the last 5 to 6 years since I've been here. So I'm going to start out talking about some translational work that I've been doing, and it's really focused on estrogen receptor positive breast cancers, which is the most common kind of breast cancer that we encounter. In those patients who have estrogen receptor positive breast cancer, you might also hear me refer to it as hormone receptor positive breast cancer. Estrogens obviously play a very important role. This is a very simplified schematic of a steroid cell, which in breast cancer is an epithelial cell. You can see in postmenopausal patients where there's no ovarian production of estrogen, it's all based on extragonadal estrogen synthesis from the adrenal gland, where there's a complicated number of steps in the hormone metabolic pathway that ultimately culminate in aromatase converting adrenal precursors androstenedione and testosterone to estrone and estradiol. My patients always get very concerned when I tell them about this pathway, that we're going to actually block their aromatase with aromatase inhibitors and that they're going to have lots more testosterone, which I assure them is not actually going to happen. We do have really good drugs for these patients. Aromatase inhibitors are the mainstay for women with postmenopausal breast cancer. They serve to block this transition of the adrenal precursor steroids to estrone and estradiol, which essentially hook up with the estrogen receptor, which is a transcription factor and causes progression of disease. We have selective estrogen receptor modulators, or a drug called tamoxifen, which actually interact with the estrogen receptor itself, and selective estrogen receptor degraders, which actually cause degradation of the estrogen receptor. These are all great drugs and they work for most patients, but unfortunately about 20 to 30% of patients actually have intrinsic or acquired endocrine resistance, which is actually a huge number of patients. There are various reasons and mechanisms for this. Most of them are not actually very well understood. But for instance, if a patient progresses with metastatic disease and we sequence their metastatic recurrence, about 40% of patients will have an ESR1 mutation, which basically means that the estrogen receptor no longer needs estrogen. It's just ligand independent and it can go on and do its transcription without it. So we need to have a better understanding of endocrine resistance. There are very few biomarkers that can actually predict response or resistance to endocrine therapy. We only test when there's signs of progression. So we sort of give everyone anti-estrogen pills. If they progress, then we test their tumors to see if there's more targeted therapies that we can give them. And we don't really have a great way to predict resistance, and we need better mechanisms and then more novel agents to actually treat these endocrine resistant tumors. So when I started here, I was fortunate enough to be introduced to Nima Sharifi. He's actually a prostate medical oncologist who was at the Cleveland Clinic when I started. And this is our little schematic here again. And what I'm going to be talking about for the next few slides is about the enzyme 3-beta-HSD1, which you can see here is actually just one upstream of aromatase. And he and his group discovered a single nucleotide polymorphism in the gene HSD3-beta1, which encodes that enzyme, which actually has an allele frequency that's somewhat common in the population, about 5 to 32%, varying by genetic ancestry. Functionally, this actually results in two very distinctive phenotypes. You can see the adrenal restrictive phenotype is in the cell on the left, where the 3-beta-HSD enzyme is functioning properly. It's rapidly degraded in the cell, compared to the adrenal permissive genotype or phenotype, which is on the right, where this single base pair change makes this enzyme resistant to degradation in the cell. And so there's an ultimate buildup in these androgen precursors, androstenedione and testosterone. So I'm going to take you to the prostate cancer world for just a moment, where androgen receptor positivity is very akin to estrogen receptor positivity. Most prostate cancers are very hormonally driven as well. And similar to postmenopausal women who have extragonadal estrogen synthesis, the treatment of prostate cancer is castration. So they also have extragonadal synthesis of androgens. And in these patients who have metastatic castration-resistant prostate cancer, it's sort of similar to estrogen receptor postmenopausal breast cancer. These patients have a buildup of these androgens, androstenedione, testosterone, DHT, when they have the adrenal permissive phenotype. And what it results in is actually very clinically significant differences in outcomes for these patients. So the homozygous wild type in the green line is the adrenal restrictive, so 2 copies of the more common variant with the normal enzyme. The homozygous variant down here in the red is the adrenal permissive phenotype, which is 2 copies of the variant enzyme. And you can look at 5-year survival here. It's about 60% versus 22%. Huge, huge difference in clinical outcomes. So I'm going to pause here for a second and just say, obviously, people are wondering, how does androgen receptor work in breast cancer? We don't really know. We don't really understand the significance of it, something that we definitely need to study. And what we are currently studying. And then, great, there's a clinical difference, but is there anything meaningful in terms of treatment? Because it's great to find differences that are really important, but can we change the treatment that we deliver to these patients? And it turns out we actually can. In women who have triple negative breast cancers that are androgen receptor positive, there are studies using androgen receptor antagonists that work at the androgen receptor, and they actually improve survival in that patient population. Because estrogen is so important for estrogen receptor positive breast cancers, the androgen receptor really hasn't been studied, even though it's actually also present in about 60% of breast cancers. We don't routinely test for it because until we've sort of studied this more in prostate cancer, there really hasn't been a need to have additional drugs in this patient population. So this is sort of what stimulated the entire research project that I've been working on for the last 5 to 6 years. We started with sort of a pilot project. I was able to get data and DNA samples from a collaborator at Hutch, who had run a population-based study linked to a cancer registry of stage 1 through 3 breast cancer patients who had already collected all of the demographic, clinical, treatment, and follow-up data. And they also had 644 postmenopausal patients with hormone receptor HER2 negative breast cancer who also had germline DNA that we could sequence. So we sequenced HSD3-beta1 in these patients, and we found that 47% of patients had the adrenal restrictive phenotype and genotype, and 9% had the adrenal permissive. This is very consistent with what we would expect to see in the general population. When we looked at demographic and treatment characteristics across these 3 groups, the really only difference that we saw was that, as expected, because this variant is more common among non-Hispanic white people in the population. It was also more common in the adrenal permissive patients. Similarly, there were also no differences in cancer or treatment characteristics, although, as we all know in research, we really parse the data. And I think if you look closely, even though not statistically significant, you can kind of get a sense that these adrenal permissive patients just don't look quite as good. They are less likely to have a low-grade tumor. They're less likely to have a lumpectomy, more likely to have chemotherapy. And I highlight this box down here just to point out that over 90% of our patients in this study were on endocrine therapy. In the general population, this is probably closer to 70%. Patients in this cohort were highly treated and really has to do with, reflects the low event rate that we saw. So on the left here, distant metastatic recurrence, you can see the adrenal permissive have higher cumulative incidence of distant metastatic recurrence and worse breast cancer specific mortality. So higher breast cancer specific mortality than the adrenal restrictive type, similar to prostate cancer. So this is a Cox regression. And you can see here, this really kind of proves our hypothesis that being adrenal permissive in breast cancer, similar to prostate cancer, results in worse outcomes. 5-fold increase in development of distant metastatic recurrence compared to the adrenal restrictive, and a 3.5-fold change in breast cancer specific mortality. So we took this data from our little pilot and I applied for a Cancer Consortium New Investigator Award with the hypothesis that in our breast cancer patients, having the adrenal permissive variant would increase intracellular androgens, and it would actually interfere with aromatase inhibitor binding to aromatase. Most aromatase inhibitors are non-competitive and can be knocked off of aromatase, and that this would provide excess substrate for conversion to estrogen and have worse breast cancer outcomes. We're in the midst of enrolling for this study. This study has really taught me a lot about how to run a clinical trial, the frustrations with running a clinical trial. It's taken years off my life, but we have been able to actually quite successfully enroll onto it. And it has helped me learn a lot about being a clinical trial investigator. Essentially, what we do is we take postmenopausal ER-positive breast cancer patients and we utilize information from their diagnostic biopsy. We give them 3 weeks of letrozole, which is an aromatase inhibitor, and then we collect data from their surgical specimen. Some of you may not know what a window trial is, but essentially we do a short-term intervention. Many different kinds, can be drugs, can be other kinds of interventions between biopsy and surgery. And then we kind of look on the front end and the back end and see if there's any changes. Specifically, the primary outcome of this study is to look at absolute change in Ki-67, which is a proliferation marker, and has been shown in neoadjuvant endocrine therapy studies to change in as little as 2 weeks. When we sequenced our first 33 patients, so we're still enrolling, but we sequenced them, we actually found a really high number of adrenal restrictive patients. I'm not really sure why specifically, fewer heterozygous, but still that sort of 9 to 10% adrenal permissives. For those of you who have quickly done your math, you know that this is actually 3 patients with the adrenal permissive genotype. So unfortunately, at this point, I can't really say much about the different genotypes because we only have 3 patients with the less common variant. But our first 33 patients look exactly as expected. They're postmenopausal. They've taken about 3 weeks of the window trial letrozole therapy, more likely to be non-Hispanic white. They have intermediate grade tumors that are early stage T1 and 2 and pathologic N0. We wanted to have something out of all of the work we've done so far. So because we'd been extracting RNA, we did whole exome sequencing from the biopsy specimen and the surgical pathology to look at differential expression of genes. And we analyzed 15,000 genes, 350 or so were differentially expressed, meaning they were different from the biopsy and the final surgical pathology with the intervention of the aromatase inhibitor in the middle. Possibly not surprisingly, most of those genes were downregulated, which probably relates to the fact that we've been giving them medications that decrease proliferation. We're working on pathway analysis. This is just a free online tool that you can use to put in genes that are either up or down regulated to look at the pathways that they're associated with. The upregulated genes were associated with immune function and signal transduction. The downregulated genes look very focused on cell cycle, which kind of makes sense, but more analysis of this to come. Our next steps for this study are to obviously complete enrollment. We have 56 patients out of 68 enrolled, continued the genotyping. We've been working on quantitating expression of our estrogen, progesterone, and androgen receptors in Ki67. This process actually is done manually by our pathologists, and it's subject to inter-observer variability. So we've been working with some of our pathology colleagues to actually have a machine learning algorithm whereby we can train a path program essentially to differentiate between epithelial and stromal cells, and then quantitate the expression of the epithelial cells with the stains. So that's taken a little bit longer than expected, but should result in sort of more consistent reproducible results. We also will do more on exploration and changes of gene expression, and hopefully we have enough adrenal permissive patients to actually stratify by genotype. So more to come on that. I think one of the things that I have become quite interested in, and actually I'm fortunate to currently be participating in a grant writing course to try to get this clinical trial up and running, is among women who have estrogen receptor positive breast cancer recurrences. So still staying along this line of estrogen endocrine therapy resistance. And this slide is really just a snapshot to show it's a culmination of a bunch of NSABP trials among node negative and node positive patients to show that the local regional recurrence risk, which is breast cancer recurrence in the breast or kind of the lymph nodes around the breast, is anywhere from 2 to 10%, which in breast cancer is considered actually rare, quote unquote, although 300,000 women will be diagnosed with breast cancer this year. So you can imagine if 10% of them had a recurrence every year, that actually results in thousands and thousands of women who do experience local regional recurrence. Unfortunately, the prognosis for these patients is quite poor, particularly those who have non-breast recurrences. So in the axillary nodes on the ipsilateral side or other nodal basins, 5-year distant disease-free survival for these patients is somewhere in the range of 20 to 30%. So it's quite poor. And these patients, when they recur, it's really a harbinger for ultimately developing distant metastatic disease. So despite the fact that there are thousands of patients who experience local regional recurrences per year, there are 2 randomized controlled trials in this space, only 2. One was published in 2003 and basically showed that if we add endocrine therapy to these hormone receptor positive breast cancers, they do better. So this was tamoxifen was approved by the FDA in 1998. So this study was actually just ongoing. Many of these patients never got tamoxifen with their first primary breast cancer. So not surprisingly, when we gave them anti-estrogen medication, they did better than if we just observed them. The other major trial in this space is a trial called KALOR, which is now at this point about a decade old. It was a larger trial looking at any kind of local regional recurrence that was resectable. So ER positive, ER negative, and it really randomized patients to receive chemotherapy or not. And as I had previously mentioned, the local regional recurrence is a harbinger for eventually developing distant metastatic disease. So no one really wanted to enroll their patients on this study because everyone was pretty convinced that they needed to give them chemotherapy. Chemotherapy should, in theory, eradicate any sort of microscopic disease in the body that's already present. For estrogen receptor negative patients, which I'm not showing here, giving chemotherapy was quite beneficial. But you can see here the survival curves completely overlap for the ER positive patients, and chemotherapy was not shown to be beneficial at all in this patient population. So just to pause, we have a 20-year-old study that shows endocrine therapy helps, a decade-old study that shows chemotherapy doesn't help. So we're left with patients who have already been on endocrine therapy for their primary cancer. They recur. They most certainly have endocrine resistant disease. And really the only option we have for their systemic treatment is more anti-estrogen medication. So you can see the problem here. Many of these patients are endocrine resistant. We give them sort of a slightly different kind of anti-estrogen medication, but none of them are actually FDA approved other than the ones that we already give in this space. There are still not biomarkers to predict response in this patient population. When these patients recur, we actually don't routinely test their tumors to see if they have some of these mutations that we know we have targeted drugs for. And we need to continue to better anticipate this resistance in these patients. This particular patient population is also very tricky to study. The patients and the treatment that we give them are very heterogeneous. One patient may recur after having had a mastectomy and an axillary lymph node dissection. One patient may have recurred after having a lumpectomy and radiation. They could have had 6 months of endocrine therapy or 5 years of endocrine therapy, and they present. We don't actually classify these tumors in any specific way because we only have one treatment option, which is to give them more anti-estrogen therapy. So we don't actually have a reliable biologic way to classify these tumors, and we treat them all essentially in the same way. And again, I've noted that there's few studies in this patient population. How we treat these patients is actually also quite variable. Axillary recurrence, we do an axillary lymph node dissection. That's probably the most standard type of treatment. If someone has an ipsilateral breast or chest wall recurrence, we can do repeat lumpectomies, although the data for this, the safety of this was a single arm prospective trial that included 58 patients. We can do a salvage mastectomy or a wide local excision. The question of should we remap for sentinel node biopsies is all over the place, and practice is highly variable. We radiate or re-irradiate, and then again, I draw your attention to the fact that we give repeat endocrine therapy to these patients. Or do we? So I showed you all the KLOR data, which showed that chemotherapy doesn't work in these patients. And yet when we surveyed our local regional work group in the Translational Breast Cancer Research Consortium, this is a survey of 35 medical, surgical, and radiation oncologists, 50% of patients are getting, 50% of clinicians are giving chemotherapy to these patients, reflecting their inability to look at the data and their fear that if they don't give really aggressive systemic therapy to these patients because they are probably already endocrine resistant, that we are going to undertreat these patients. So there's really a need to better understand these patients in general, and then also to improve upon some of the therapies that we're currently giving. So as we thought about what would be better therapies, we draw our attention to some patients who we also know suffer from endocrine resistance, and that's our patients with metastatic breast cancer. As I mentioned previously, about 40% of metastatic breast cancer patients, if we sequence their metastatic sites, they will have an ESR1 mutation, for instance. There are definitely other mutations that we know about and have drugs to target, but we know that a lot of these patients ultimately are endocrine resistant. So the Monarch 2 study on the left here was the addition of a CDK4/6 inhibitor to fulvestrant, which is a selective estrogen receptor degrader and had previously been monotherapy for metastatic ER-positive breast cancer. Fulvestrant, I will just tell you, is a monthly and gluteal injection. So not something that we would really ever consider giving to an early stage breast cancer patient because they wouldn't take it. But it's really uncomfortable for our patients. But it's all we have currently. Abemaciclib is a CDK4/6 inhibitor. It has to do with cell cycle arrest. And you can see that it was given for 24 months on this study. And you can see that even beyond the medication being given, the survival curves continue to separate, with abemaciclib being additive in terms of survival benefit. So this is abemaciclib and fulvestrant is now currently the standard of care for metastatic ER-positive breast cancer. And there is some data that it can help overcome endocrine resistance. On your right, you see this is looking at progression-free survival. So metastatic breast cancers, we think about progression, not necessarily cure. And elacestrant is an oral SERD, so not an injection. There's a lot of research going on with oral SERDs so that we don't have to do monthly injections for our patients. And you can see here the addition of elacestrant in these second or third line treatment patients to standard of care, which is giving more anti-estrogen therapy, and abemaciclib showed an improvement in progression-free survival. So this was actually just recently approved in the metastatic setting for only patients with ESR1 mutations and improves progression-free survival in this patient population. So from the metastatic literature, we want to figure out how we can apply this to our patients who, although not metastatic, are actually very likely to become metastatic. And can we apply these medications to some of the patients who have just at the point of detection only local regional recurrence? We've been working on this study schema for the last 2 years, and essentially we plan to enroll presumed local regional recurrences. Everyone gets staging to ensure they don't have evidence of distant metastatic disease. When they are confirmed to be isolated local regional recurrence, we would have a pragmatic 2-arm trial where the treatment arm would get, after surgery and radiation, abemaciclib and ideally a novel anti-estrogen. one of the partners that I'm working with on this is a medical oncologist with lots of contacts in the pharmaceutical industry. So we've been talking with various companies about novel anti-estrogen medications. And then we need to follow this chemotherapy arm because there are some patients that the medical oncologist will be deemed too high risk, and we need to understand their outcomes. There's a lot of translational endpoints in this study. One is looking at advanced imaging with something called FES PET, which the nuclear tracer actually binds specifically to estrogen receptors, and then can help us better understand sensitivity of that imaging modality for some of these estrogen-resistant tumors, or sorry, endocrine-resistant tumors. We also plan to collect cell-free DNA, at initial diagnosis, after surgery, and then every 6 months to look for signs of progression, and then to look at their initial tumor, their recurrence, sequence them, and try to understand genomic alterations and get a better sense of how we can predict endocrine resistance. Also, we really want to understand, are there patients who do need chemotherapy, or can most of these patients be treated much like our metastatic patients with just abemaciclib and some novel anti-estrogen medication, which can help overcome that idea of endocrine resistance. So ongoing work, I would say most of my work in the translational space really has sort of circulated around this idea of endocrine resistance and how we can better manage our patients who do have resistance to the traditional therapies that we give them. I am doing okay on time, even though I know I'm talking fast. I'm trying to catch up a little bit on time. These next sets of slides really have to do with some of the collaborative work that we've been doing within our group, both within our group and multi-institution. I'm going to kind of have to zip through these slides a little bit, but one clinical quandary that a lot of us face is, or that we have faced, is contralateral axillary metastasis. This occurs in about 6% of new or recurrent breast cancers, and really is thought to be due to aberrant lymphatic flow. So you can see here, this is lymphoscintigraphy. The technetium-99 was injected into the breast, and then it travels all the way across the body to the contralateral axillary nodes. Currently, this is considered stage 4 in the AJCC guidelines, but I think a lot of us are wondering whether it truly needs to be considered stage 4, or whether it can be considered stage 3C, which is more like regional metastatic disease. The studies in these patients are very small. They're very heterogeneous. The inclusion criteria are highly variable. So a group of us came together to do a multi-center retrospective comparison of patients with CAM that have no evidence of distant metastatic disease, locally advanced breast cancer population from the same institution over the same time period, which was 2016 to 2023, and then compared to a distant metastatic cohort. We put together a classification of these lesions because the studies, again, kind of all over the place, and there are different types of CAM. So there are patients who present with their initial primary breast cancer and they have nodes on the other side. And then there are patients who we treat and then develop CAM later, which probably have different pathophysiologic ways that the cancer got to the lymph nodes, because some people have already had surgery and radiation. We looked at our cohorts. We only had 63 CAM patients. We were very strict about our entry criteria into the study, and matched our locally advanced breast cancer patients on age and year of diagnosis. And then we have our metastatic cohort. And you can see there aren't a lot of differences. Specifically, I'll draw your attention to no differences in hormone receptor subtypes, which is important. Treatment of these patients is obviously quite different. Metastatic patients, as I mentioned before, many of them don't get chemotherapy up front if they're estrogen receptor positive. Many of the locally advanced patients, however, did. This is not the treatment of the CAM. This is treatment of the primary cancer. Most of the patients did not get chemotherapy for this original patient population. When we looked at the CAMs, we found that most of them were in the setting of already having had a breast cancer. So only 14% just presented initially with CAM. The others were either in the context of an in-breast recurrence or they just occurred on their own. All of the patients in this study had axillary surgery. That's how we identified them. And then I just want to say a lot of treatment for these patients. So if we march down the pathway of treating these patients with multimodality therapy, surgery, chemotherapy, and radiation kind of all generally come together, at least at the academic institutions who participated in this study, of which there were 11. When we looked at overall survival, this is a Kaplan-Meier curve again. You can see our locally advanced breast cancer patients did the best. CAM patients were in the middle with a statistically increased risk compared to locally advanced breast cancers, but they did quite a bit better than the patients who had true metastatic disease. So visceral disease, bone disease, CNS disease. And so we are very hesitant to say, let's reclassify these patients as stage 3, because we know that many of the patients in this retrospective study who were selected for surgery in this very intensive multimodality therapy were also obviously probably already doing better than the patients who were not selected for this study. But it is increasing evidence that perhaps in some of these patients with multidisciplinary discussion, with good functional status, and without any evidence of distant metastatic disease, we should potentially consider offering operations for these patients in multimodality therapy if it's going to improve their survival. This has certainly, I think, changed the way that our group has thought about management of CAM. I think a lot of these patients we never even saw. The medical oncologists would just treat them palliatively as stage 4 disease. But now we have many more discussions about how to treat these patients. And I would say in our group, we're sort of leaning more towards operative intervention for most of these patients. Another study that I'm proud that we were able to contribute data to is a large international study trying to better understand axillary management after neoadjuvant chemotherapy. There's this classification of lymph nodes with residual disease when we do sentinel node biopsies, when patients have converted from clinically node positive to clinically node negative after neoadjuvant chemo, where they have isolated tumor cells. So under the microscope, you can see a cancer cell here, here, here. Really low burden of disease, but the predominant way we think about it is if there's any residual disease, it's chemotherapy resistant, and we dissect. There's obviously a lot of issues with axillary lymph node dissections in terms of patient morbidity. So we're always trying to think about ways where we can avoid doing it. You can see in these 3 trials, or 2 randomized controlled trials and a retrospective study at Memorial Sloan Kettering, if you're found to have isolated tumor cells on your sentinel node biopsy and you do have an axillary dissection, you're very likely to have additional disease in your lymph nodes on the dissection. There are a randomized controlled trial currently where patients were randomized to axillary dissection versus no for residual disease in the lymph nodes. Everyone receives radiation. Isolated tumor cells not included in that trial. So as we anticipate the results of the Alliance trial, which is what I just mentioned, these patients actually aren't even included. So in theory, we'll know how to treat them, but they're not included. So a large retrospective study was done around the world. We were able to contribute data from our site. And of the 182 patients who underwent axillary lymph node dissection after they were found to have isolated tumor cells on their sentinel node, about 30% had additional positive nodes, but 72% of those were just additional isolated tumor cells. What about outcomes in those patients? So these are cumulative incidence curves stratified by patients who did or did not receive a completion axillary lymph node dissection. And I think you can see that the curves are completely overlapping in terms of any axillary recurrence, isolated axillary recurrences, and any invasive cancer recurrence. Really no difference in management. This has hugely changed practice, at least in our group, and I think in a lot of academic centers around the country where we were previously dissecting all of these patients with isolated tumor cells. I now no longer really dissect them. There are certain circumstances, depending on the patient and what else we find in how many nodes have isolated tumor cells, but there really does not appear to be much of a difference, and axillary dissection is likely not needed in these patients. We've also had the fortune to participate in some industry-sponsored trials recently in our group. This is called the Selene trial. Things have not changed since probably Dr. Wood was doing lumpectomies. That we still have positive margin rates anywhere from 15 to 40% in the literature when we do a lumpectomy. Because the breast is largely fat, it is also very difficult to assess intraoperatively. There's only one institution that I know, MD Anderson, where they actually just pause surgery for about 30 to 45 minutes so the pathologist can look at the margins. In the operating room, that is obviously not going to be possible for most places. And so there is a need to better understand how can we assess margins intraoperatively so we can avoid taking patients back for a second operation. This device uses optical coherence tomography, which essentially produces high-resolution images of subsurface tissue structures, so 2 millimeters deep into the lumpectomy specimen. We scan the specimens once they come out, and then we essentially read the images while we're in the operating room. Essentially what we're looking for, this is the histopathology slides. You can see this DCIS here, cancer cells within the basement membrane, and you can see this correlate on the imaging that we see in the operating room. You can also see it down here. We have this like halo around hyperechoic center. So in the operating room, ideally what we're doing is scanning each side of the lumpectomy specimen, trying to identify any of these features that look concerning, and then we go back right then and there in the operating room and take additional margins. This study has now closed to accruals, so we await the results. We were the second highest accruers to the study, so pretty cool to be involved. This is something that I definitely never thought I would see in my lifetime. Patients, patients ask me all the time if I can use a robot, and I'm like, no, this is breast surgery, we don't use robots. But it turns out we do. So Dr. Javid and myself and Dr. Inchauste have been fortunate to be able to participate in a robotic nipple-sparing mastectomy trial. You can see me here trying to learn how to use a robot. I did very little robotic training. Dr. Javid did none in her residency. So we had to come every week and practice it's using the single port surgical system. You can see here, there's 3 instruments right in direct alignment with a camera that moves at both the elbow and the wrist. This is me getting near a bowel picture, which made me extremely nervous because I no longer operate in any other part of the body except for just here. It's really cool. UW, I think we have historically not been included in some of these because we just haven't done as much research, but with our increasing research program here, we are the only site that's involved in the entire like northwest part of the country here, which is really cool. This is us doing one of our first robotic nipple-sparing mastectomies. Our normal inframammary incisions are under the breast. They're anywhere from 9 to 12 centimeters long. The single port you can see enters through a 3-centimeter incision in the lateral breast, which Dr. Inchauste has told me is incredibly difficult to do what she needs to do through. As I'm sure Dr. Stein could probably attest, doing reconstruction through a 3-centimeter incision is not necessarily ideal. But we randomized patients to open versus the robot. There are certainly upsides and downsides to both of them, but it has been really fun to be able to participate in the trial. We are actually currently the highest enrolling site on the trial out of all the sites, even though we were the last to be brought on board, which is also a little feather in our cap. And this is us at our first robotic nipple-sparing mastectomy. I'm just going to take another couple minutes to point out that we do a lot of clinical outcome work. See you. This is a great study. And we really have the fortune to do a lot of this work with our residents and colleagues, worked with Dr. Clark and Dr. Sham to better understand genetic testing among patients with high-risk breast, ovarian, pancreatic, and prostate cancers. With Dr. Crary, who is a medical student, is now one of our OBGYN residents, and Dr. Parker, who's one of our pathologists, thinking about lobular neoplasia, which is sort of a high risk lesion. How frequently does it upgrade if it's seen in relation to a synchronous cancer in the breast? Dr. Brennan here, after one of her rotations at Harborview as a 4th year, came to me and said, I really don't think we're doing a great job educating our patients upon discharge. The paperwork is like super confusing, and I don't think patients really understand. Can we look at this in breast cancer? So it was her idea. We supported her in looking at that. We looked at all the comprehensive cancer centers around the country, and she found that the reading level for most of the breast surgical material was actually at the 11th grade level when you put it into a variety of different online tools to look at reading level, where it should be at the 8th. She presented this at ACS last year, and it got actually quite a bit of press in the ASCO Post and ACS, just kind of because it's important that our patients understand what we're telling them about making their surgical decisions. Dr. Stein, Dr. Martin, and I have been working on looking at some of our reconstructive techniques after we do these larger lumpectomies and have increasing oncoplastic post-lumpectomy reconstruction. This is called a LICAP. You can see here that this patient has kind of a defect after their original lumpectomy surgery. This skin here on the lateral chest wall is deepithelialized, and I like to tell patients that the plastic surgeons sushi roll it up and shove it into the lumpectomy cavity for a volume replacement technique. And the outcomes actually are pretty good. We can accomplish much larger lumpectomies, so void mastectomies in many of these patients who don't want them or just flat out refuse them. And then one fun thing is that, anytime we do a new technique where we're doing something within the breast itself, we really want to understand how does this impact our long-term surveillance of our patients. So we actually partnered with our our radiology colleagues to look at these patients' subsequent mammograms to understand, is this technique going to make it more difficult to detect recurrences? And it turns out that it's really not. It's just a sushi roll of skin and fat that shows up quite nicely on the mammograms and really shouldn't interfere with our subsequent surveillance of our patients, which is also nice to be able to show. This is one of the Hem/Onc fellows who's presenting our gene expression data from the study that I talked about earlier in December at our big medical oncology breast cancer symposium meeting in San Antonio. And then our star residents who we torture all the time with our many millions of clinical ideas. And Malia and Jamie, we have been so fortunate to work with them, and they presented at multiple national meetings. And Jamie actually just won an award at the Washington, Oregon ACS for one of her talks on breast cancer. So I know that was super fast. I tried to catch up. I just wanted to try to give a broad scope of some of the stuff that I've been doing. I want to say thank you, first and foremost, always to our patients. They are at the center of everything that we do. We are so lucky to have patients who trust us to take care of them. They inspire a lot of our research questions, and they allow us to do research on them, even if it's not necessarily going to benefit them, but maybe breast cancer patients in the future. I have the most incredible partners and colleagues. This is a bunch of us at the Mariners game last Sunday for Pink at the Park. I thought Pink at the Park, like everybody in Mariners in the stadium, would have pink t-shirts because it was Pink at the Park, but it turns out most people wore Mariners gear, and a large cohort of us wore pink shirts up in the upper decks, but we did get on the Jumbotron twice. And then, of course, my family, who puts up with late hours and lots of work and is always super supportive. And hello to my mom, who is also watching on Zoom. So thank you all. I've left not much time for questions, which is intended. I don't know.
We have Dr. Hamilton, I'm seeing here. How do you think patients get via item nodes and even assignment? This kind of result of incomplete surgical radiation versus lack.
Thank you so much, Dr. Linden, for that question. Dr. Linden is one of our medical oncologists, and she is always asking the same question, and no one knows the answer. I think she's hoping that I've had some new data on this. I think we don't know. In our type 1 CAM patients, those are the ones that present with their cancer and the nodes on the other side. I think that it probably, and you could see in that picture that there is some disease that sort of just transfers probably in the mediastinum. But there could be alternative pathways. We don't really have a great understanding, but essentially it really has to do with some sort of disease or prior surgery or radiation in that ipsilateral axilla that's causing translocation of cancer cells sort of across the chest into the contralateral axilla.
Dr. Flanagan, I have a couple of comments and a question. So,
oh, my mom's, look at there. Mom, your camera's on.
So Bonnie, we're very proud of Dr. Flanagan also. So my first comment is, this is incredible, and I think inspiring to the residents and to the faculty that are here to see an example of a true surgeon scientist and the breadth of what you're doing. And my second comment is you reinforced my decision when I was recertifying for general surgery a couple of weeks ago to not pick the breast module. That's kind of my question. I chose abdomen, which I thought I would probably do better in than breast. So, and you just reinforced that clearly.
Perfect.
My question is, you touched on patients at later stages of disease and running out of options for what their therapies are. In lung cancer, we are starting to find that we are rebiopsying some of them at later stages to look for molecular markers or targets that may have an impact. How is that evolving in the breast cancer world? Rebiopsy is easier for breast cancer patients in general than lung cancer patients.
Not always.
Yeah, it depends on where things are.
Mhm.
But are you seeing that that is something that is increasing in breast cancer also, and you anticipate that as more therapies like you're talking about become available, that might be an increasing avenue of how we test for improvements in later stage therapy?
Yeah, definitely. Currently, if someone is diagnosed with metastatic breast cancer, they do try to biopsy the metastatic site because there is literature that shows, which I didn't really include here, but we even have it for our CAM patients. So specifically those who had their initial breast cancer and then presented later with CAM, that you can actually see changes in hormone receptors. So most patients, whatever they first presented with, they will still have, but there are a subset of patients, I think in our CAM study, it was about actually 20% of patients change hormone receptors. And so especially those who are undergoing endocrine therapy, for instance, they can develop therapeutic resistance and become triple negative. So we definitely always attempt to biopsy the metastatic site. The problem with breast cancer actually is that the bone biopsies are not super reliable, and many of our patients have bone disease. CNS disease is the worst, also often very challenging to biopsy. Lungs, challenging to biopsy, also one of the common metastatic sites. Liver, also. Yes. So the ideal is, of course, to biopsy those metastatic sites and sequence the tumors and try to understand whether they're actionable mutations there. And I certainly think we will continue to do that in the patients in whom we can. Dr. Linden, who you already heard from, is working a lot on FES PET with, and there are other imaging modalities that are coming out where the radioactive or nuclear tracer actually targets specific receptors. So we can use that as sort of, instead of a biopsy, say like, okay, yeah, this is strongly estrogen sensitive because it's lighting up on FES PET, versus that site doesn't light up on FES PET. So it's probably has less estrogen expression. So there probably will be increasing also advanced imaging techniques that we can use in patients in whom we can't biopsy to try to get at some of these questions of like, what are they going to be able to have in terms of targeted therapies?
I just want to say thank you. You've been such a great mentor to myself and Sarah, and we're just really lucky to be able to work with you with such a good. And my question was looking at the patients you're enrolling with the isolated lateral breast tumor recurrence. Is the question, well, two things. Is the question whether they're getting neoadjuvant chemotherapy versus adjuvant
Abemaciclib.
Yeah. Is that the intervention, like neoadjuvant versus adjuvant?
No, because so it's a our proposal is a pragmatic trial. So very unlikely we'd be able to get patients randomized onto this study because of the fact that it's a very heterogeneous patient population. We likely wouldn't be able to we wouldn't have enough patients to stratify by various prior treatment that they've had. And also the realization that some medical oncologists will just not be willing to give repeat endocrine therapy, even if there's a CDK4/6 inhibitor involved. So in order to follow all patients, we would let people treat as they want to treat. And if they think it's an appropriate patient to put on the study, we would put them in that arm of the study, a single arm trial. And the control group, which is what you're asking, I think you're getting at, is actually going to be the historical controls from KLOR. So we would use that as our control population. The problem with this is that while I feel like I see it not infrequently, and sometimes I have multiple patients in one clinic with local regional recurrence, in general, it's not super, super common. Not all cases are ER positive. And so we will it necessitates having multiple institutions to enroll patients on this trial, which is why we're trying to do it through the TBCRC. And people have a lot of opinions. So we're trying to get a trial that like works for everyone, and then we would just enter those patients who people deem needing chemotherapy into a registry arm so that we can collect their samples and analyze them, but not necessarily have them in the treatment portion of the trial. So it's actually, you're highlighting a really important point, which is that it may be similar to Keylor in the sense that people are more likely to enroll similarly. They're more lower risk patients. It's kind of a risk you take in a pragmatic trial. But I do think talking with the medical oncologists and just generally at the TBCRC, there's a huge amount of support for getting this trial off the ground because we really don't have a lot of options in these patients and we need better treatment strategies.
Several minutes over, so anybody else that has questions?
Yeah, thank you so much.